So the problem with GERD is, when it starts, it's mainly a symptomatic disease. You get the atypical or typical symptoms, but as it progresses, um, it can develop into esophagitis or inflammation of the esophagus. And then that esophagitis can lead to ulcerations or peptic strictures, Barrett's esophagus, which is the precancerous change from the squamous tissue to columnar tissue, and then ultimately to adenocarcinoma, which is the most feared problem with chronic acid reflux. So when we talk about reflux symptoms, you get mild symptoms, which is defined as symptoms less than 1 day per week, or severe, which occur greater than 2 days per week. And then there's the esophageal symptoms or syndromes, and then the extraesophageal syndrome, similar to what we already spoke about. The esophageal is just a typical reflux and chest pain, esophagitis, strictures, Barrett's, carcinoma. The extraesophageal syndromes are laryngitis and dental caries, pharyngitis. People get sinusitis, idiopathic pulmonary fibrosis, and recurrent otitis media. The thing about the extraesophageal syndromes, I think that's where we also drive a lot of our referrals from non-gastroenterologists and non-primary care doctors when people start getting these extraesophageal syndromes. And when we talk about the final step of chronic acid reflux and esophagitis, you can go to the next slide, is when we're talking about esophageal adenocarcinoma. It's a cancer that has increased almost 600% since 1975, or the past 45 years. And it's still, although it's treatable, the 5-year survival rates are only about 20%. So it's really something that with proper therapies and proper proper interventions, we can decrease the risk of. So when you look at GERD, there's over 134 million prescriptions and over-the-counter medications that are used on a yearly basis for GERD. About 1/4 of Americans have clinically significant GERD. Out of that, about 10.2 million actually visit a doctor every year, and there's about 6.7 million upper endoscopies that are done every year because of GERD. So it's a very common disease state. When you look at the patient journey of GERD, it all kind of starts in the same way. I think people start with mild symptoms first, and you go to lifestyle modification. You stop eating acidic foods or spicy foods or caffeine or carbonated beverages, and then if that doesn't, or stop eating late at night if that doesn't work, the next step is to go for over-the-counter medications and prescription medications. And after a while, I think a lot of patients are looking for something else, for something more durable that doesn't have to do with taking a pill every day. And then you start going down the procedural intervention route with diagnostic workups, and then ultimately therapeutic workups. So when you look at medications, you have the typical antacids like Tums or Mylanta, and then the H2 blockers, which are kind of out of vogue now because of the fact that a lot of these have been taken off the market for the possible carcinogenic risk. And then ultimately onto the PPIs, which there's numerous prescriptions every year for the PPIs. But the problem is, we don't know where to stop, right? People get started on PPIs, but what's the end point to it? And I think that's something that patients are really looking, that they really want to get away from, because you don't know when to stop the medications. So the thing that I think a lot of patients, with every patient going on the internet and going to Google and looking up PPIs, I think one thing that really comes up are the side effects with long-term use. And there's a whole host of side effects that have been talked about, whether it's dementia or stroke or risk of heart disease, increased ammonia risk, chronic kidney disease, increased risk of infections like C. diff, or increased risk of bone demineralization and osteoporosis. And I think a lot of the patients that I see in the office are, they come to me because they want to get off of their PPIs because of the long-term risks. So the biggest, I think, the ultimate problem with the medications are, they kind of put a Band-Aid on the problem. They decrease the acid content in the reflux material, but they don't really do anything for the reflux. You're still refluxing. And then when you're really, I feel like when you're really trying to solve the problem of reflux, you know, you really need to address the anatomic abnormality at the GE junction. And that's where that's really where either surgical options or procedures like the TIF come into play when we're trying to recreate this anti-reflux barrier. So when you look at the ideal GERD treatment, you have on one side what doctors want. I think as a doctor, we want our patients to be out of pain, to have their symptoms controlled. You want them to use as little medication as possible. And from the objective improvement, you want to see a decrease in esophagitis. You don't want a lot of side effects with the medications that we're giving. And I think from a patient standpoint, I think patients just want to feel normal. They want to be able to sleep at night without regurgitating. They don't want to have to rely on taking a pill every day, and worried if they forget their pill, or are they going to be in pain after they eat something, and from a surgical standpoint, I think all patients nowadays want everything to be as minimally invasive as possible if they're going to pursue um, some type of a surgical correction. And so when you look at the spectrum of TIF in terms of mild symptoms to severe, the spectrum from mild symptoms to severe GERD, I think there's a definite role for interventions. Out of the 6.7 million patients with GERD, only less than 30,000 of them actually elect for surgery, and I think that's mainly because people don't, they want to look for something as minimally invasive as possible. It's hard to get patients to really elect to have a surgical procedure, and I think that's where something like TIF really comes into play, because I think patients are a lot more willing to undergo an endoscopy, and if we can correct the problem with that, I think we can capture a lot more patients and it will really help them.
So I think Dr. Dasani definitely touched on the fact that it's a mechanical problem and that the medications really just mask the symptoms. And honestly, I think when I talk to patients, that's one of the biggest misconceptions that they have is, they've basically been suffering, some patients, for 10, 20 years. And they said, oh, well, I've been on this medication, but now it's not working as much. And they really didn't understand that they were still refluxing the whole time, or that they were still having an issue. And I think that's one of the biggest things that we try to educate them on, is that, hey, this is a mechanical problem. So to have and to not have reflux, you really need to have the esophagus working correctly. You need to have the end of the esophagus in the abdomen. You have to have the stomach all in the abdomen, with an appropriate angle of hiss. You need to have a diaphragm that has a small hiatus, with the phrenoesophageal membranes kind of intact, and you have to have, on top of that, the adequate LES pressure. And so when patients come to me, I really feel like they're usually on the end of the spectrum. They've been suffering 10, 20, 30 years, and they said, well, now my cough, they don't know where it's coming from. They think it's from reflux. Or now they finally got a scan and it shows a huge hiatal hernia. Or, my GI doctor is finally kind of doesn't know what else to do. And now they say that, to seek surgical correction. And although, we're happy to take care of those patients, I think part of the point of today, and part of the point that we're doing with the patients and the providers, is educating on the fact that, because this is a mechanical problem, what are ways that mechanically we can fix this, and in the least invasive way. Hiatal hernia repairs have come a long ways. Basically, since the invention of X-ray, we've been able to tell that patients have diaphragmatic hernias. So basically in the late 1800s, early 1900s, you know, with the invention of X-ray, we've been able to see, hey, some patients' stomach are above the diaphragm, and that's abnormal. And try to figure out, well, what does that cause, if anything, and how does reflux and heartburn and all that have to do with all this? And I think as early as the 1940s, Dr. Allison and Dr. Barrett really played big roles in describing kind of the importance of the hiatus, the importance of the crura being together, and that, you know, angle of His, or the, you know, esophagogastric angle in preventing reflux. And I think now it's pretty much generally accepted that you cannot fix reflux without first treating a hiatal hernia. I think what we've learned, and Dr. Thosani will speak to this too, is that, you know, I think patients have more hernias than we think they do, and they have larger hernias than they think they do, and even, you know, small hernias of 2-3 centimeters ended up being much bigger hernias, and you really can't get an adequate treatment of the reflux without first fixing the hiatal hernia. And that's why, although some surgeons may feel like, well, why am I partnering with a GI, or why am I partnering, you know, this has only increased the amount of surgeries that I do, not decreased the amount of surgeries, and it's made my surgeries easier rather than more difficult. And I think it's because if you're really going to treat a reflux well, you have to not underestimate the importance of the hiatal hernia. In the 1940s and 50s, Dr. Nissen and Dr. Belzy started to develop operations for fixing the reflux. I think they had found ways that, hey, we can fix the diaphragm and we can fix the stomach being in the belly, but how are we preventing reflux? And I think Dr. Nissen really played a big role in that. You know, his first patient was on accident. It was like a gastric ulcer perforation that he ended up doing a wrap and treating that, but he was able to learn that with that wrap, he really decreased the amount of reflux they were having. But it's been, you know, even though it's been in use for, you know, 60, 70 years, it's been, you know, tried to be modified in many ways, because it did have a lot of side effects. It did have a lot of bloating and dysphagia and issues. And I think that's kind of where the Toupet and the Dwarf fundoplications came about, proposing partial fundoplications to try to minimize this bloating and dysphagia, because we have kind of figured out, hey, we know we need to increase the lower esophageal sphincter, and we need to increase that strength. But if we do it in an incorrect way, patients are suffering other symptoms, and we don't want to cause more problems than we currently have. I think DeMister and Johnson really went even further and came up with this kind of loose, floppy Nissen, and that's kind of the gold standard now, where you do a 2-centimeter wrap and really try to minimize how much bloating and dysphagia you're going to get, but trying to do the 360 wrap, you know, the 270 wrap, the thoracic approach. Obviously, there's a lot of papers, and you know, we could spend 2 days just arguing about which is the best procedure. But I think what we can come up with is, we know that the hiatus needs to be repaired. We know that the angle of His needs to be put in its appropriate position. The LES has to be in the belly and the abdomen, and that you need to have some kind of anti-reflux wrap. Laparoscopy and robotic has really kind of taken it even further, decreased complications, decreased morbidity, but it's still an extremely underutilized operation. Less than 0.2% of eligible patients are ever offered surgical correction. And I think it's because of this long-standing negative connotation with, you know, the cure may be worse than the problem. And I don't think that's entirely true. And I think some of the stuff that Dr. Thosani and I are trying to do is to even improve that even further and make the cure where it's much better than the problem. In this picture on the bottom right, I do want you to see how, you know, the short gastrics really get taken down, the vessels between the spleen and the stomach, and you really need a broader area to do your Nissen fundoplication. Go ahead, Dr. Thosani.
Yeah, so when, you know, as Albert was showing there, I think it's a good surgery. It works. I mean, we all know that Nissen works great for reflux, but you know, with the advent of the TIF, we think that we can that we can provide something for patients that works as well from a clinical standpoint, and that makes the whole surgery and procedure a little bit easier. So when you look at the TIF, and we'll go through a video in a little bit for those who haven't seen it yet. It's a pretty slick device actually. It's basically a long overtube that goes over top that you put your scope through, and you advance this down into the esophagus, which is probably the hardest part of the procedure in all honesty, because it's a 20 millimeter tube that goes down. So I definitely dilate first with bougie dilators up to about 60 French before I put the tube in. And then you put the device down, and the goal is to basically grab tissue at the GE junction, pull it into the device, and create an esophagogastric plication. And you do this by grabbing the tissue, wrapping, and plicating to get to at least a 270-degree valve, as you can see on the picture on the right. So when this is what the TIF looks like. So the picture on the left here, that's when we start the TIF. You can see there's a lot of laxity, and the scope it's floppy where the scope is coming through the GE junction there. So that's probably a Hill grade 3 valve there, and that's why people reflux there. There's probably a small hiatal hernia there, and there's just no barrier for the acid to come up. And when we do the TIF, this is what it looks like after the procedure is done, and then after 5 years, this is a picture of how it looks. So the scope, when it comes through that GE junction, it's nice and tight against the tissue, so there's just not a lot of room for reflux contents to come up. So this is a short procedure on a short video on the procedure. This is the device here, and it has a bendable top there. So you put the scope through the device. Sorry, showing that you're creating a 270-degree valve. But you put the scope through the device here, and you have to use a lot of mineral oil to get it through and to keep it nice and lubricated. And then after the dilations, you put the scope and the device down, which again is probably the hardest part. And then you retroflex to get a good view. And it takes 2 people, one person to hold the scope and one person to control the device. And with the helix, you grab tissue at the GE junction and you pull it into the device. So you're creating this esophagogastric communication here with the plication. And at this point, you create suction on the device, and you pull the esophagus down to relieve up to a 2-centimeter hiatal hernia, and then you deploy these plicators or serosal fasteners, and then they stay, and then over time it causes an inflammatory reaction, and it creates this nice connection. And you do this around the whole valve to create at least a 270-degree valve, and that's what creates the barrier to reflux. So the goal is to create at least a 3-centimeter in length and 270 degrees around the valve. All right, I think we can go to the next slide. So when you look at the data for TIF, probably the most landmark study that came out was a tempo trial, which looked at durability of 5 years post procedure. And when you look at the different things that they were looking at, it was a lot of scores based on questionnaires. So you have this GERD HRQL score, which is a score that looks at typical GERD symptoms, and then you have another score called the RDQ, which looks for symptomatic regurgitation, and then the other score is RSI, which looks at atypical symptoms. So when you look from pre-TIF to 5 years, you can see over that period of time, based on the questionnaires, patients have done really well, and a lower score means that their symptoms are improved. So the 5-year data is quite good. So when you look at the specific markers in the GERD health-related quality of life scores, you know, pre-TIF to post-TIF. So when you look at pre-TIF, which is the blue bar, and then post-TIF, which is the purple one, when you look at all these measures on what patients reported their symptoms as, you know, symptoms have gotten uh, have been much improved. Less heartburn, no heartburn when they lie down, no heartburn or less heartburn after meals, um, less heartburn that wakes them up from sleep at night, less regurgitation, less chest pain. So it's the 5-year data is really showing that this is a good procedure. When you look at the percentage of patients over multiple studies that are off of PPIs after 5 years, it's also good. You know, over I think on average over 80 to 81% of patients after 5 years are off of their PPIs. When you compare that to Nissen, I believe the data for Nissen is about 84% of patients are off of their PPIs. And when you look at more objective data, there's about 70 to 80% of patients, when they're rescoped, are completely healed from their reflux, from their esophagitis, sorry. And then when you look at patient scores determining if they're satisfied with their health condition, when you look over 5 years, patients seem to be quite satisfied with the TIF. So in this slide, it's similar data, but this is data looking at concomitant TIF, at a surgical hiatal hernia repair followed by a TIF, and again, when you look at the orange bar, that's prior to the procedures, and when you look at 12 months, patients have really had improvement in all their symptoms. I think the one thing that patients still get, which is much less than the data with the Nissen, is you know, so some patients still have some gas and bloating, but I think it's much less than the traditional fully surgical repair. And when you look at the diagnostic tests that are involved with this procedure, you know, every patient is going to have an EGD. With the EGD, they're going to likely have some sort of pH testing. If they don't have a lot of esophagitis, we should consider some form of pH testing, whether it's a Bravo probe or impedance testing. If patients have dysphagia, I usually like to do a manometry test to just be sure that we're treating a right symptom and not some motility disorder. And a lot of surgeons do like a barium esophagram too, just to see the actual size of the hiatus.
So Dr. Thosani briefly kind of talked about the concomitant TIF. Essentially, that's basically that I do a robotic or that we do a hiatal hernia repair, and then after doing the hiatal hernia repair, he does a TIF rather than doing, you know, a Nissen or a toupee fundoplication. The pros to kind of a C-TIF is basically that it's extremely safe. You're already have done the hiatal hernia repair. You know, you're already done an EGD. You've already had a bougie up to about 52, 56 French. So the majority of the risk is really just the introduction of the device, which is minor. At the beginning, when we first started doing them, I did stay in the room and you know, basically watch the whole procedure. If there was, you know, would be any issues, you know, I could still be in the abdomen, and I could still be able to perform any surgery that I needed to do. You know, after about, you know, 15, 18 cases, essentially got to the point where, you know, I never have to really do anything after the hiatal hernia repair. It's basically letting Dr. Dasani do the TIF, and then the patient is done. So at that point, that's when we started asking for 2 ORs, and really, you know, I'm operating on another patient while he's doing the TIF on the prior patient, and that's just kind of how comfortable we got with the procedure. I do all my hiatal hernia repairs robotically, so I have 2 robot rooms, and we'll start the hiatal hernia. I give him, about a 45-minute warning. Once I'm done with the hiatal hernia repair and place the mesh, he'll come in. He'll do the EGD. You kind of get instant feedback on the repair from a gastroenterologist, and then he does the TIF, and by that point, the next patient's already back in the second room, and I'm starting a hiatal hernia repair. He takes, Dr. Thosani is pretty fast, and he probably does his TIFs in about 35 minutes. It takes me about 45 minutes to do a hiatal hernia repair, so I mean, he has time for a cup of coffee in between cases. So it works out, pretty well, and the safety is there. I do think that the TIF provides a better anti-reflux valve. I think the reason is because I have done the job of fixing the crura. I've done the job of fixing kind of the angle of his. I've elongated the esophagus and created a GE junction that's in the abdomen. So a lot of the key things that we need to do have been done surgically. And so now it's a matter of doing a fundoplication externally or doing a fundoplication internally. Our patients just complain of less gas bloating, less dysphagia. They go, on a liquid diet on a clear liquid diet for a few days and then a full liquid diet for a couple weeks. And I just get much less symptom and pain with the hiatal repair and the concomitant TIF. I think part of the reason that it is better is because a lot of the fundoplication is internally rather than externally and creating. I have to make it very tight. When I do the Nissen, no matter how loose I try to make it, it is still a tighter repair. And I have to take down all the short gastrics. I have to mobilize the stomach a lot, more than I do with the hiatal hernia repair alone. I do think that the hiatal hernia is under recognized, and I do think the CTIF improves the TIF alone. I do think that with a lot of these patients, even if they don't have a big hiatal hernia on EGD, their GE junction isn't really deep in the abdomen. It's kind of at the level of the hiatus, and you're relying on the TIF device to bring down the GE junction. Obviously, with good results, but I think when you can mobilize the distal esophagus and really bring that GE junction down, I think it just helps with the long-term results. I think the main failure of a TIF is a hiatal hernia, and it's usually an underappreciated or underrecognized hiatal hernia that was already there. I also think that by repairing the crura and getting that phrenoesophageal membranes tighter, they get an increased barrier to prevent, reflux, right? Rather than just relying on just the GE junction, you're really kind of relying on both the GE junction and the crura. I think the importance of the esophageal length is also, improved with a concomitant TIF and a surgical repair of the hiatus. And I do think I allow for a better valve length for Dr. Thosani.
Just to go over that, I think that's very important. Is that in the beginning, I think it's something that we found out in some of the early cases, that the TIF goes much better when you can when Dr. Amini or the surgeon can elongate the esophagus into the abdomen as far as possible. It just gives a lot more tissue to be able to grab to do the endoscopic fundoplication. So I think that's quite important. And the other thing I do want to stress, and I know I said it before, is when we started doing these, I wouldn't dilate. I would just try to put the device in, and I think we had we had some difficulties with the patients. So I think it's I can tell Dr. Amini, once I get a 58 French or a 60 French bougie in, I know I can do the TIF. So I think at that point he goes to the next room and starts the case. So it's a good measure of whether or not we'll be successful.
Great point. This next slide is a little bit kind of our team approach. I do think TIF has allowed both a patient and physician acceptance that was just not there with the Nissen fundoplication. I think you know, PCPs, GIs, they do anything in their power to avoid the surgery, right? And I think with the endoscopic TIF, we've been able to say, hey, you know, now, you know, if they don't have a hiatal hernia, we can avoid surgery altogether, or hey, we can do this minimally invasive option. And even patients, you know, as they research and look into this, they say, well, are there any options other than Nissen? I've heard, you know, horror stories of Nissen, or can't vomit. The question I get more than everything is, I'll never be able to vomit again with a Nissen. I'm not entirely sure why you want to be able to vomit, so why you worry about that so much, but that's like one of the most common questions I get. And so Nissen has this kind of negative connotation, and I think the TIF allows us to really enter the door and broaden the patients that we treat. And I think if you have a GI partner that really understands the importance of the hiatal hernia, you know, even a 1 centimeter, 2 centimeter defect, but he knows this is the right patient, or this is the patient that he really thinks having that hiatus repaired, well, that just allows for the concomitant TIF and allows for more anti-reflux surgery than I think we've been doing, and getting that number from 0.2% to, you know, over 2%. I think by doing the team approach, it also really allows us to offer a spectrum of endoscopic interventions, minimally invasive interventions, reoperative surgery. We've even taken a patient with a lynx and with a Nissen to a redo hiatal hernia repair and concomitant TIF with good short-term results and hope long-term results as we follow them. I really think that you provide patients benefit for patients that really would have never gotten a surgical opinion, or who would have thought that a surgical option was not really adequate for them, or that they really didn't understand medical therapy and its deficiencies. And I really think it helps us kind of stimulate innovation and improve collaboration. You know, the way Dr. Dasani and I started was obviously in the hepatobiliary world. We both have special interests in pancreas cancer and in complex HPV. And I think, you know, this is just a natural process in that, as well as, you know, what are ways that we can improve the minimally invasive approach, and what are ways that we can improve the collaboration to reach either more patients or to treat patients better.
Right. I think one important point to that is that, you know, and as Dr. Amini said, this all started for us in terms of the team approach from our other disease states like pancreas cancer that we treat. But patients love that team approach. You know, when a patient can sit down and meet the surgeon, meet the gastroenterologist, I think it makes a big deal. And how we do it is we make sure that if a patient is referred to either one of us, that we're thinking of the procedure. We make sure that the patient sees the other partner in very short order. In the future, we've been talking about actually holding some office hours at the same time, that a patient can see me and then see him, and we can just get a plan and figure out what diagnostic studies need to be done. But I feel like patients really love that team approach, and it definitely draws a lot more patients in.
I did want to show a little bit video of a kind of a robotic hiatal hernia repair. Part of the reason I wanted to show this video is because when this patient got sent to me, it was sent as a very small sliding 2 centimeter hiatal hernia. And I think, as you can see kind of right away, this is the diaphragm and the crura on both sides. And you can see that there's a huge defect here with, you know, the top 20% of the stomach going through the defect. And I think part of the reason why it's so difficult to see this is because when you kind of do the EGD, you end up insufflating the stomach, and you end up bringing the stomach back down into the abdomen, and you kind of lose a little bit of that ability to see exactly how big the hiatal hernia is. And on the upper GI, which is kind of the other way we do it, it's just very challenging to see where the stomach kind of starts and the esophagus ends. My big thing when I start doing a hiatal hernia repair is to try to get around the esophagus, you know, as soon as I can. And once I'm able to get kind of around the esophagus and I'm able to kind of retract that, I'm able to then really identify the right cruce. You can see the right cruce right here, the left cruce right here. And it's not like we enlarge this in any way. This is a defect that's probably 5-6 times bigger than normal. And you can see the amount of space in here just by taking off the the hernia sac and taking down some of the attachments of the esophagus. As I kind of fast forward, I'm basically kind of getting 360 degrees around the esophagus. All these attachments, and here you can kind of see where the esophagus and the peritoneum kind of meet. All these attachments are going to kind of prevent the G junction from laying down nicely and staying down nicely in the stomach. They're just going to kind of pull the esophagus back up into the chest and pull the G junction back up into the chest. And that's why without a good hiatal hernia repair, a lot of these patients get recurrences. And the other difficulty with fixing the hiatal hernia as opposed to a different hernia is most hernias that you fix, you're able to close the defect completely. The hiatal hernia and maybe the inguinal hernia are some of the few where you can't close it completely, right? Because you can't get rid of the esophagus. The esophagus still has to come through there. So you're never going to get a complete closure. You just got to get as tight of a seal as you can. I think that's one of the biggest reasons for failures. And as we learn and as we get better and do it more robotically, hopefully those recurrences decrease. But I think when you do a straight TIF or when you just kind of treat medically, you're really kind of fighting against the anatomy there, and you're not really giving that patient a decent chance. I'm going to kind of fast forward through this a little bit more to kind of show you a few things, but I wanted to show this because the G junction is kind of difficult to see from the outside, obviously, but usually the Penrose and kind of where the esophagus and stomach ends kind of gives us a good idea of where it is. But you can see all this fat that's on top of here, and you can see how I haven't taken down any of the short gastrics. These are things that as a surgeon you normally do when you're doing a Nissen. You take down a lot of these short gastrics, so you're going to need to mobilize the entire stomach. And I don't take down really any of the short gastrics over here outside of a few little attachments at the very, very top. And honestly, I don't really even take down the hernia sac off of the stomach completely. I do take it off of the esophagus completely. I don't take it off of the stomach completely because I don't need that space anymore. So that helps with trauma, that helps with inflammation, that helps with motility, that helps with the bloating and decreased potential injury to the vagus. It's really just an easier operation and even gets our times down even more to get them even faster. This is now as I'm starting to repair the hiatus. And you can see the esophagus is right here. And all of this was basically an opened crura or a dilated crura with a huge hiatal hernia. And so I have to bring all of that back together. So I use these sutures, permanent sutures, and I bring the crura, the right and left crura together. And I have to take it all the way to the esophagus because I don't really want to leave any laxity there. And that's that second barrier that we talked about on top of the lower esophageal sphincter being a barrier, this crural repair, being another barrier for preventing reflux. And you can see the amount of length now that the esophagus has. More than 5 centimeters are in the abdomen now with the G junction, somewhere over here. Just fast forward a little bit more. I think this was my last slide. I have a 52 French bougie in place. As Dr. Dasani said, he ends up dilating to a 56 and a 60 to get his scope, ready to introduce the TIF device. I do it to about a 52 because I do want that, that tight area there. Fast forwarding a little bit more, I think this is my last suture, and that's, now I feel like an adequate repair of the hiatus, barely enough room to kind of get my instrument through there. And then just a last kind of picture. I end up usually putting a biologic absorbable mesh. Again, I don't think the point of this talk is to talk about the importance of mesh or not to use mesh. I do think if the hernia is a decent size, the biologic mesh does add a little bit of scarring and strength that I potentially wouldn't get without the mesh. The mesh goes 360 degrees around the crura and around the esophagus, and I place it behind the spleen on the left upper quadrant and behind the caudate lobe and on the right side. And so as you can see now, the mesh is kind of circumferentially around. I've repaired the crura. I have about a 4 centimeter gap here with the mesh, about 5 or 6 centimeters on the other side. And now I've got a nice repair of the crura. I got a new an adequate angle of His, which is really important in trying to get a reflux prevention. I have the crura brought in on both sides, and I have the length of the esophagus. So now to do a Nissen, I get all the time, they're like, well, you're already there. Why not do the Nissen? Well, I haven't, like I said, I haven't taken down the short gastrics. I haven't immobilized the entire greater, as much of the greater curvature as I normally do. I haven't taken down kind of the fat pad that you always see on the esophagus. I've really minimized the amount of inflammation and trauma to this area. And I've given Dr. Dasani the most amount of room to be able to kind of do his TIF and his fundoplication with the most amount of esophagus and the most laxity of the LES. So kind of in conclusion of that video and the C-TIF, I think the crura is really an integral component of GERD pathophysiology. I really do think you need that, and I think the presence of hiatal hernia is really under-recognized and underappreciated, and I really appreciate Dr. Thosani's ability to acknowledge or diagnose the fact that, hey, a concomitant TIF would be better long-term for the patient. And I think that's that team approach that we talk about. I think GERD control is really dependent on both the crura and the construction of the anti-reflux valve. I think lap Nissen is utilized extremely low in the percent of eligible patients. And I think concomitant TIF can really be a bridge to either doing more surgical patients or getting more patients in the door for more surgical procedures. I think the concomitant TIF is safe and effective alternative to lap Nissen and really improves the patient and provider acceptance. And C-TIF really allows me and Dr. Dasani or GI and GI surgery to really develop a multidisciplinary team approach to GERD and allow for better long-term and better use of anti-reflux procedures for a mechanical problem.
And when you look at the TIF procedure, I mean, it really does emulate the traditional surgical principles. It helps to reduce a hiatal hernia. You can repair a larger hiatal hernia with a joint approach. You can elongate the intra-abdominal esophagus. You can approximate and tighten the fundus around the esophagus. You can recreate the dynamics of the angle of His and restore the distal high pressure zone. So it really does everything that anti-reflux procedure is supposed to do. So what are the patients that we can bring for TIF? So according to the company, the patient should be greater than 18 years old, have daily bothersome GERD symptoms, despite PPI therapy, have an anatomic disruption at the G junction, and have a Hill grade valve, that's allowing for reflux contents to enter the esophagus. You definitely want to have proven acid reflux by either an endoscopy with esophagitis or Barrett's with an ambulatory pH monitoring, or a barium swallow showing a hernia. If you're doing a straight TIF, the hernia should be less than 2 centimeters. And if you're doing a concomitant TIF, it can be as big as possible. And you want to show that there is some evidence of either esophagitis or abnormal pH study while the patient is chronically on PPI therapy. In terms of the other tests that are done, again, the EGD, Bravo capsule, or other pH impedance study, manometry if they're having dysphagia. I think these are important. And so, who don't you want to do a TIF on? If these are very large patients with a BMI greater than 35, I think that the ability for improving reflux by recreating that valve is probably lower in these patients. If the hernia is greater than 2 centimeters, you have to have some sort of surgical approach. If they have a paraesophageal hernia, you really shouldn't be doing a TIF here. There'll be, there's danger of catching that fundus as it's going up through the hiatus. If they have severe esophagitis with ulcers and stuff, it's probably better to get that healed first with maximal amount of medical therapy first. If they have a diverticula, you don't want to be putting plicating devices through there. Obviously, if they have varices, they're not a candidate. Esophageal stenosis, mainly because if they have a bad if they have a bad reflux stricture, it'll be very hard to get the device through there. And if you start dilating up, there is a risk of perforating, so that may not be the best patient to do it on. If the patient has very limited neck mobility, it may be difficult to get that device in. And as I said multiple times, that I think the hardest part of the procedure is actually the beginning, just getting that device through. So if they can't extend their neck well, you may have a hard time actually introducing the device. If they have a lot of osteophytes of the cervical spine too, same thing, you may not be able to get the device in and possibly cause a perforation. So I think you can see a lot of this on the initial endoscopy, and you really have to pay attention to the upper esophageal sphincter as well. Next slide. So in terms of serious adverse events, I think there's definitely a risk of an esophageal laceration. I think a full perforation is low, but there's definitely a chance of an esophageal laceration, especially in the upper esophagus, and that has happened to me a couple of times. I didn't have to repair all of them, but there have been times that I decided to clip the area because the defect looked a little deep. There's a low risk of a pleural effusion, GE junction leak, a tear. Post-op bleeding is low. I think we had one patient that got started on anticoagulation about a week after the TIF, and they did have bleeding, mainly from the plication sites. Mediastinitis, low gastric perforation. Again, there's not a whole lot you can do. I mean, as long as there's enough room to retroflex, you really shouldn't be causing any perforations in the stomach. So the evidence of TIF, it's been studied in over 100 peer-reviewed papers in the surgery and GI journals, with outcomes for over 1,500 unique patients. There's been over 25,000 patients treated since 2007. And just a little bit of history with the TIF, the device is a newer device now. The older device, you could only deploy one plicator at a time. Now we deploy 2 at a time, so it's just a lot easier to use. The outcomes are good, with consistent improvements in subjective and objective measures of GERD in randomized controlled trial data, and the safety profile is excellent. So when just a little more about how Dr. Amini and I work. We work in a large hospital system in the Phoenix metro areas, where there's about 4.5 million people in our area. Dr. Amini, so as Andrea said, I'm trained in gastroenterology and advanced endoscopy, so I'm very familiar with a lot of advanced endoscopic procedures. And I think TIF is something that I think that any gastroenterologist or surgeon can learn. It just it takes a little bit of finesse actually just to get the device down, and once it's down, it's pretty slick, and I think it takes about 10 to 15 cases just to kind of understand what you're doing. There's a very definite sequence of maneuvers that you do. And you know, when I first started doing it, you know, it didn't really make sense to me why you have to do this first or this first. But after 5, 6, 10 patients, you know, it really started making sense. And it I don't use a second um, and second endoscopist to do the procedure, but I just have my tech holding and manipulating the scope, and for me it works out well. Um, Dr. Amini, you can talk about your bio a little bit.
Yeah, I'm trained in GI oncology, and so the majority of my cases were foregut and GI oncology, so gastric cancer, pancreas cancer. I did a lot of robotics. I do robotic Whipples, and kind of robotic foregut surgery was kind of a natural space for me. And I think part of the reason why I got interested in doing these cases was I really think that, you know, that area is really underutilized. Robotic surgery can play a big role, and I think the more minimally invasive we can make the procedure, the better. And I think that's part of kind of my interest in my wanting to team up with Dr. Dasani. We get EGDs, Bravos, manometries, and upper GIs on all our patients preoperatively.
So I think we can start to skip some of these slides because we talked about it. I think there's a lot of questions, but Dr. Mini, do you want to talk about the reimbursement codes really quickly for this? I think is important.
Sure. So lap and robotic are coded the same. And so if I was to do a robotic hernia repair, and I almost routinely use mesh, here you can see kind of the payment for if I did it by myself, and the amount of RVUs if I did it by myself. If I do it with Dr. Thosani, we have to bill it as co-surgeon. So my reimbursement essentially goes down, you know, $600, or my RVUs go down. But you're able to bill at a higher rate. You're able to bill at 125 at 125% of the total. So essentially, you know, you will get paid less for doing it as a co-surgeon, but in essence, it's a quicker procedure. Instead of an hour and 15 minutes, an hour and a half, it's usually about a 45-minute procedure for me, and we're able to do you know 6, 7, 8 in a day. I think the big key is when Dr. Thosani does it by himself, you know, he bills it as an EGD with fundoplication. When he does it with me, it has to be billed as kind of a co-surgeon, and so you have to, you know, dictate it appropriately, and then you bill at 125% of the rate. For joint procedures, you don't need to get prior auth for the TIF, and that helps a lot of our prior auths. And then you know, for straight TIF procedures, commercial payers do need prior auths.
Yeah, for Medicare patients you don't need, but for commercial payers we use this third party called Priya that's set up by Endogastric Solutions, and we're pretty successful in circulating authorization.
This is our team. This is our last slide. So, you know, I've got, you know, first assist. I've got a circulator nurse. I have, you know, the anesthesiologist, and then Dr. Thosani and his assistant. And then we do a lot of our cases robotically. So we're in the robot room. And I usually try to get 2 robot rooms, and we do it about every 3 weeks or so, 3 to 4 weeks, try to get somewhere between 6 to 8 patients.